I am really excited for my next guest. Amy Gleason has been involved in Doge and CMS for a while now, and I am excited to sit down with her to get a behind the scenes view into some of the work that they've been doing, particularly around the pledge, interoperability. And I wanted to ask and have you hear, what is the personal story that's driving Amy to improve healthcare? Because I think it's very important to understand that kind of context. And I'm so glad she's agreed to come on camera with us. Let's get to it. Amy, welcome to the program.
Thanks for having me.
I'm so excited. It's been years since you and I have had this kind of a conversation. We've been a long time, know each other from the Twitter days,
Yeah.
right? Now X, and it's just so great to see you.
You were the first person I ever had a tweet up with, so it's great to see you.
That's right. It was in Vegas, right?
Yeah.
That was down at the, what's now the Hilton, I think it was.
Yes,
That was a lot
very
of fun. Yeah, that was very good. You look great, by the way.
Thank
You
you.
look great. You're doing so much travel. I see your travels all over the internet. You are just doing the whole circuit.
Yes, I think we're trying really hard in this administration to get out and be with people and hear what problems are and try to work on ways to solve them.
And you're keeping the airlines in business. I like that. I like that a lot. Well, Amy, it's just so great to have you. Tell us a little bit about yourself and your role in the government.
Yeah, so I am the administrator at the U.S. Doge Service, and I'm also a strategic advisor to CMS and HHS. And I mainly have been in the private sector for most of my career. I started out as a nurse in the ER and then built a lot of health technology, electronic medical records, supply chain practice management, co-founded a company after my daughter was diagnosed with a rare disease, and then did a stint in the federal government at the U.S. Digital Service, and then went back to the private sector and came back in this role last January. A lot of people don't know a lot about what Doge does on a day-to-day basis. So obviously I do a lot of work in healthcare, but we also work across a bunch of different federal agencies. And our goal is really to modernize technology and bring that to the federal government. So some examples of the other projects we work on are modernizing the student loan program with the Department of Education and the FAFSA. We've gotten that form down to be less than 15 minutes for someone to complete. We're working on the non-immigrant visa application for the State Department ahead of the World Cup and the Olympics, make sure we can get people in. And then we did the passport. If you renew your passport, you can now do it all online. We do a lot with the VA. We're working on a lot with disability claims to bring that time down. We even do things like the Firearms Act and getting forms modernized for ATF and many more. So we're really doing not just healthcare, but a lot of different modernizing. And we take lessons from all those and can share them as well.
Thanks for that context. I really appreciate that. And I also appreciate the fact that you brought up Morgan, because that was kind of how we met. That was the original story that we did that chat in a long time ago, when back then when we used to do those tweet chats together.
Yes.
Well, obviously healthcare is very personal for you. You ER nurse, you worked in healthcare, like you said, on the private sector. You obviously have experience, going through what Morgan went through at the healthcare. So this mission of yours that you're on is very personal to you. Is that right?
Yes. So for those of you that don't know, my daughter was a competitive gymnast and cheerleader and a very active, healthy child. And then she started having these rare symptoms that didn't seem connected at the time. They just seemed like kind of normal childhood things. She had rashes on her elbows and her knees and her fingers, but it seemed like that might be from the mats, because she was, hitting the mats and gymnastics a lot. And she got sick a lot, but she was around a lot of kids. She was getting strep throat and other things. She had her tonsils out. Then she started breaking bones, and some of them were in gymnastics, not that surprising. But then she started just like breaking her foot walking down the street. And she broke her elbow just barely hitting it on a table. And we kept asking, like, why does she keep breaking her bones? Is something wrong with them? And they kept saying her bones look good. And so this kind of just kept continuing. She started losing all of her tumbling skills, and we couldn't figure out why. We thought maybe it was a fear from breaking bones. But it turns out that she had a rare disease that was kind of accidentally diagnosed by a skin biopsy at a dermatologist. So they were just trying to figure out these rashes because she'd had all these steroids and treatments, and it wasn't really helping them. And so they did a biopsy, and it came back that she has this rare disease, juvenile dermatomyositis, that's a vascular systemic disease. So that's why it was affecting her in all these strange ways. But the challenge at that time was, ironically, I had been working with electronic medical records and the new HIEs and trying to share data. And her doctors couldn't see any of that. Her data was siloed across all of these different systems, and each doctor was only seeing their piece of the puzzle. And even though, as a mom, I was trying to tell them everything going on, it didn't really seem important to them. So they're in their one little cycle. But I've always believed that if someone had seen all of that information in one place, that they would have said, why is an 11-year-old going to the doctor this much? And how can we work on this together?
I love that, and thank you for sharing that story. I mean, when I first heard it, I was just like, back then, siloed data was the default, right?
Right.
We had interoperability as a concept, but it certainly wasn't executed the way we have now. And even then, we've got a long way to go. I think you can agree, we got a long way to go for interoperability, but we're making strides. And one of the things I was reading about recently about some of the work you're doing at CMS, or the CMS is doing, is around this sort of CMS Health Tech Ecosystem. Can you tell me more about that?
Yes. So the last time I was in government, I worked on this thing called data at the point of care. And it was really to help take claims data that CMS had and give it to providers. So at least you had a map of the overall structure a patient had. You knew what doctors they had seen. You knew some of their meds and their problems, and at least know where to go get the rest of the clinical data if you needed it. It was the first book fire implementation. It was very exciting. But we wrote that into a rule in 2020. I worked with Alex Muggy on it. And it doesn't go into effect until January 1, 2027. So I came back after being gone for 4 years, and here we are. We still haven't moved the needle on this thing that obviously if we rewrote that now, we would write it differently. So at CMS, we tried to take a step in last spring and say, okay, how can we really get interoperability to work? And how can we do it in a way that doesn't take 7 years to go into effect? So we kind of did an RFI, we did a lot of listening sessions, and then last July at the White House, we launched this health tech ecosystem. And the idea is to get industry to come together voluntarily and to make a pledge to work together to actually see this stuff happen in 6 months and a year. So we set target dates of March 31st and July 4th. We started with 60 companies. We had all the major labs like Anthropic, OpenAI, Microsoft, Google, all came in. Then we had all the major EMRs, Epic and Meditech and Oracle, Athena, ClinicalWorks, and some TrueBridge, like smaller ones, Elation. And then we had networks. All the QHINs came in. And then some different kind of networks like BeWell, Zeus, Innovacor, Datavant, that are kind of different kind of networks.
Right.
And then a bunch of patient apps and providers and patients, of course. So really, we came together. The first thing was just to fix interoperability for some main pieces. First, patient access without having portal logins or having to remember every doctor you've seen. Be able to know who's getting your data. So even though it's hard for patients to get their data, it seems like it goes everywhere else without people really knowing why or how it goes there. So kind of like you can see your credit report, we want people to be able to see where their data is going. And then on the provider side, fix some of the treatment challenges that have been going on around what is treatment and how do you decide who you can share with, to make that a little more concrete and easier to do, to delegate access. And then to get payers into the mix a little bit on operational. So first, providers want that claims data, and then payers want to be able to get quality measure data and the clinical data that supports a claim. So that's kind of the interoperability part of this pledge. The second part was really giving patients access into different tools, because we really believe that we've been talking about patient empowerment and patient engagement and giving patients tools all the way to the Dr. Google kind of phase. But AI is really changing how this can happen. And there's this real drive from patients that are getting involved. And so they can't have that kind of rich knowledge if they don't have their data. And so we have 3 parts of that. One is kill the clipboard. So as I get my data that's easy without having to log into all these portals into whatever app I choose, then I can share that with my doctor with a QR code. So it will move into more stages after that, but as simple, just like you do at a concert or the airport,
Right.
here's my QR code, take my data. Second is once I have that data, having conversational AI on that that's protected and secure and private, but also the patient doesn't have to know all the things to prompt because it has your medical record and can give context. And then it can give personalized advice. And then the third part is diabetes and obesity, straight up MAHA, trying to help prevent and manage diabetes and obesity, but in a personalized way. So those are the things people pledge to. Our first milestone is March 31st, which will be like a minimum viable product for all those categories. And then July 4th expands that into a little broader scale, a little more automation than manual work, and bringing in some more standards and things.
I got a question about the pledge that you mentioned it a couple of times. What's involved with the people who have made part of that pledge? And then the second question is, can other people join in on this pledge if they want to?
Yes, please do. We're always recruiting. We want this to, so part of the idea of this is to come one, come all, come big, come small. Like we want everyone to join. We want, people that constantly we hear don't feel like they have a voice. This is your chance to have a voice. So providers, come and participate. If you're worried about compliance, send your compliance people. Like we're really wanting all kinds of voices to be there, whether they're a big tech company, small startup, small provider, large health system, like everybody in the middle. We have payers there. We're trying to create this environment where we can do this together. So once you pledge, there's different categories, and what you're signing up for depends on what category you're in. So first of all, there's a patient and caregiver category. We want to make sure that they're represented well. There's a provider or health system category, which is basically saying that they will join these networks based on this framework we said, and that they will kill the clipboard. There are payers saying basically that they will participate in these networks and share their claims data. EMRs or EHRs that will help enable their providers to do these things and support the kill the clipboard. Then there are networks that say they'll meet that interoperability framework. Then those 3 patient use cases of the patient apps that they'll do that piece. And then we added 2 other categories a little later after the July. One is friend of the ecosystem. So if you don't fit nicely in one of those categories to be able to do, but you support providers or you support payers, or we don't quite fit your use case yet, but you want to be involved in this foundational work so it can support your use case. Pretty much anyone that really believes in this mission and wants to support it can be a friend of the ecosystem. And then a state. When we launched the Rural Health Transformation Fund, we wanted states to be able to come in and be able to support this across their states. So once you pledge, you get access to our Slack channel. We have this public-private Slack channel, which if you only knew how hard that is to set up in the government. But it's been great because we can have asynchronous conversation, and then there are work group leads for all the different categories, both on our side and on the private sector side, that lead work group meetings and drive to what success looks like, what the criteria are for success, and really debate these things out with everyone where everyone can have their voices heard.
Yeah, so it's interesting because the way you describe it, it's not a standards creation body. When you sign up for this pledge, you're not signing up for, oh, you're going to be involved in creating this new rule or creating this. It sounds really more about collaboration and really getting a chance to work with your peers to make sure that, if you believe in this vision of interoperable data and sharing data, this is where you should be.
Yeah, so I kind of think of it as like a large-scale hackathon that's ongoing. I mean, really the idea of this is, what standards, it feels like all of this should work on paper, right? We've had meaningful use. We've had the Cures Act. We have TEFCA. Like we have all the fire standards. We have all these Da Vinci working groups. And I mean, we've had all of these things for years. Yet it's like all the dots didn't quite get connected together.
Right.
Like it'll work in this lane if you look just right, or it'll work in this scenario if all the things line up, but it just doesn't broadly work. So that's really what we're trying to do, is take all this foundation that's been laid by all these other things and just make it work. And the power of doing this outside of rulemaking is that if it doesn't work, you just change it the next day. And we all can agree on, oh, that didn't quite work, let's make it better. And then I think the idea is hopefully people will do this voluntarily and we don't have to do as much regulation. But if it doesn't, we can prove what works and then bring everyone along with regulation.
I think that's something we can all agree on. Regulation as a last resort, not a first one.
Yes.
So Amy, given your unique your unique position, your unique perspective on our industry, is there anything about interoperability that's got you excited?
Yeah, so I think a couple of things. One thing also alongside this ecosystem is that CMS is trying to do its part to build some foundational infrastructure that can help drive all of this without being in the way. And we don't want to build the solutions, we want private sector to. But there were 2 cases where we felt like we needed to jump in. One is provider directory. So people have been talking about this for a very long time. There are over 5,000 provider directories in the US. Providers answer between 20 and 60 requests every month to validate their information. Yet none of the directories are accurate and not very helpful. So everyone starts with CMS and PES, the NPI database, and then they go try to clean it up themselves and try to fix this and maintain it. And so we're trying to solve that by creating a CMS National Provider Directory. CMS itself has 8 provider directories internally. So we're combining those together and figuring out what we think is the most accurate, figuring out, where providers practice, how do you connect to them by interoperability, what is their licensure, a lot of information. Plus we'll eventually get to what health plans they support what data networks they participate in, all of that kind of information. But we know we can't do it by ourselves either. This is a public-private thing that we need to all work on together. But the idea is every company in healthcare IT spends effort on this. So instead, if we can just have people update one place, then we can all get the benefit and stop wasting so much time and money. $6 billion a year spent on this problem. So that's one that I think is an unlock that may be able to help with this. The other side is trust. So one of the main reasons we heard from people about why interoperability doesn't work today is that it's not a technology problem, it's a trust problem. And so we're putting identity on front of the provider directory. So a provider can use things like Clear, IDMe, login.gov to validate their identity and then do that one time. And then others can query to see if that provider has validated their identity and if they're a valid Medicare provider. So not every provider will be a Medicare provider, but a lot of them are, over 90%. So that gives you a huge chunk of they're a Medicare provider in good standing, and we know they are who they say they are because they've validated their credentials. Then if they validate on your side with that same credential, then you can lock all that up together.
Yeah, so that not only, as you're saying, will it reduce development costs, $6 billion according to your numbers, which is staggering, by the way, but also help reduce fraud and prevent some of the things that go on today where I'm not really sure, is this really the person who made that request or that referral, or that's all now handled with a single provider directory. That would be.
And it's a lot of the reason people are afraid to give data because they're like, I don't really know that it's really that doctor. How do I know it's not somebody pretending to be them? The same side on the patient perspective, we're adding this same identity to Medicare.gov. So we're putting login, IDMe, and Clear also on Medicare.gov. And then that will help to start seed that for the private sector, both for scale, people will be used to it. We've heard a lot of health systems are already putting these things in place for check-in. And so it's starting to connect the gaps. Then these apps in our ecosystem also are using the same identity to be able to validate the patient as who they say they are. So when they query through the network, instead of using portal logins or all of that, it's using their identity. And they can store things like their previous last names, previous addresses, previous phone numbers, like subscriber IDs. And that can be shared for patient matching to be able to make this an easier thing, as well as you actually know it's the patient who's making the request and not somebody spoofing it.
Another multi-billion-dollar problem, right? Patient matching alongside provider matching. That's, I'm sure a lot of people will look forward to having that one.
So I think those two things are like really exciting, but then I also just think the promise of AI is really just changing the world, as everyone has seen. And I think it's really empowering patients, and I'm really excited to see how all this comes together when they can have their rich data to be able to use AI with it, and how we can start to take a lot of the cost out of the system and help patients get answers in real time. I see this a lot with my daughter who has a lot of complex issues, as well as my 84-year-old dad. And their questions don't conveniently happen during 8 and 5. They happen on a Saturday night at 11 o'clock, and they debate, do I go to the ER? Do I call my doctor? Do I do this? And AI can really help provide access at a point where people don't have access.
Yeah, well, and speaking of AI, we know AI is based on data, and CMS just released a whole trove of data and made it available. Can you A, tell us what that data was, and then B, what are you hoping people will do with this data, and can we expect more?
Yes, so I think you've probably seen a lot of Dr. Oz talking about fraud in healthcare, and DOJ is obviously working on fraud across a lot of different areas in the government. But what we found in the data is pretty staggering. Some of it is more maybe not malicious, I can't think of that word, but where like some Medicaid patients, for example, I live in Texas, I'm enrolled in Medicaid, I moved to Oklahoma. My first thought as a patient isn't, let me make sure Texas knows I moved to Oklahoma, but I end up in 2 Medicaid plans. Or maybe I end up in a marketplace plan because I get a job or I'm now needing to move into that. Well, now I'm in 3 plans. The federal government pays parts of all 3 of those. So it's, sometimes it's up to 90%, sometimes it's 65%. It's a huge chunk that the federal government is paying. So that's waste. Right? Then there's fraud. There are these hospice fraud that we've seen, autism fraud. And so the idea of releasing data is to let people have access to this data and help us find patterns and issues with the data. And there are bounties. If you find things that we're able to enforce, then you can get a cut of that money as well. And yes, you can expect much more data coming.
All right. Well, and I got to ask you this. I got to end on this question because you brought it up a few times, Amy. Do you think we will ever kill the clipboard? And what is this new clipboard that we're going to have, or non-clipboard, if that's a better way to put it? Do you think we can do it?
Yeah, so I think, are we going to kill all clipboards by March 31st, our first target? No. But I think, our idea for this first phase is just the record sharing. Like, let's at least just get that going. They may still have to ask you some questions, but I think a lot of patients in our groups have said, even when you fill out the clipboard, you get in the exam room and they ask you all the same questions that were on the clipboard. And, I think sometimes providers say they're doing that as a second check, but I think, if you're not going to read the answers or you're not going to even record them other than scanning them in, then what was really the point of the questions? But at least we can get the data over and stop all the faxing and all of that piece. But I think the next phase, hopefully a meaningful way by July 4th, is to start using that data to pre-form some things so that you're only asked the things that you really need to answer, like current information that maybe you haven't done. And you can maybe do that in an app of your choice instead of having to log into all these different portals.
I love it. I hope that is going to be true one day, where I don't have to log into multiple portals to update my same information because I moved my address or changed insurance, and hopefully it actually propagates properly as well. So, no, Amy, you've shared a ton of great information. This has been a great conversation. Where can people go, or what's the best place people can go to learn about the pledge, the data, and all the things that you're doing, that CMS is doing?
Yeah, so the CMS Health Tech Ecosystem, the easiest way is just to Google that phrase, CMS Health Tech Ecosystem. The website will pop up. There's a pledge form right on that website. You can do the pledge digitally, and then within a day or so, you'll get added into our Slack. We might ask you some questions, but depending on the situation. We're also launching an app library that will be coming out based on these ecosystems apps. And so that will also be on the CMS website off of that same framework. The Medicaid data, that's on data.hhs.gov.
Excellent. Well, Amy, thank you so much for taking time out of your very busy schedule to be with us on camera. Really appreciate it.
Thank you so much for having me.
Hey, I really want to thank Amy for hopping on camera. It was such a pleasure to get back together with her. It's been a long time since I've had a conversation with her. I really appreciated the fact that she shared her story, her personal caregiver story, Morgan's story, and just to give us a glimpse behind the scenes in terms of her drive, her passion for helping to improve healthcare. I think, putting everything aside, we are all driven for various reasons to make healthcare better. And it was just really nice to hear her motivations. I'm also really looking forward to seeing some of the results of the interoperability work that she's doing. Hopefully some of those things come to pass, because let's be honest, we would all love to kill that clipboard and get rid of it. It's obviously not going to happen by March 31st, but maybe sometime down the road, with all of us working together, all of us making that pledge, maybe it will come true. And hey, if you made it this far in the video, we would really appreciate it if you mash that like button and click subscribe. Also, head on over to healthcareitttoday.com for more great content like this. I'm Colin Hung. Thanks for watching, and I'll catch you on the next video.